I am Dr. Janice Williams. This lecture will cover the art of diagnosis and treatment. The slides you're about to see have been adapted from F.A. Davis Company. In this lecture, I will explain how evidence-based strategies are used to evaluate and treat common medical conditions managed by the advanced practice nurse in the outpatient setting. We will also discuss, and I will explain, evidence-based recommendations for screening of conditions that you, the advanced practice nurse, may encounter in the outpatient setting. I will also demonstrate and explain the ability to link advanced practice nursing concepts with the clinical knowledge that you have acquired. So let's get started talking about the advanced practice nurse unique services and perspective. When you think about the advanced practice nurse, you're thinking about an individual who uses a care-based approach, utilizing the current research, evidence-based practice. We look at our patients from a holistic perspective. We do diagnose and treat, but we recognize that there are more factors that play into the wellness of our patient than just their physical. But we look at them holistically, looking at the social aspects, looking at the mental aspects, looking at the financial. So we look at it on a micro, macro, and a meso system. I want to take a minute to address that although advanced practice nurses are different than our physician counterparts, our perspective anyway is different because we go from a holistic nursing model where our physicians work from a medical model. We are different clinicians that work in one system for the betterment of our patients. We are not independent of each other. We need each other. Our physician counterparts need us as advanced practice, and advanced practice need our physicians. As we collaborate together, we build a stronger system for our patients and better outcomes for our patients. And some of the overlap that we as nurse practitioners have with our physician counterparts is that we all work off of our medical diagnosis. And we also all have the ability to care for our patients and make sure that we are looking at how can we assist them to acquire the best health, how can we diagnose them appropriately, and give them choices to what they feel would be necessary to help them maintain, acquire, or reacquire the best quality of life. So there are many things that we overlap with our physician counterparts in, but the basis is we work from a nursing model and they work from a medical model. The circle of caring is a holistic way for the advanced practice nurse to look at how they care for their patient. The circle of caring includes looking at not only the best research evidence, it looks at the expertise and clinical skills and attitudes of the clinician. It, it considers, we consider the social environmental context, and we definitely include the patient, what their preferences are, what their values are. And then utilizing all of those factors, we then support our decisions with the best evidence-based practice. So let's talk a little bit about diagnostic reasoning, okay, and the purpose and the goal of diagnostic reasoning. And when you think about diagnostic reasoning, you're thinking about how do we problem solve? How do we even help our patients to actually not even get sick? We're talking about preventative. And knowing that our patients have a complex story, there are many things that contribute to our patients' state, whatever state they present to us in. And there are many factors that may eventually contribute to their health. And we need to consider all of those things. So let's talk about you as an advanced practice nurse in the primary care setting. Many may have come from the inpatient hospital setting, but there are some things that are unique about the primary care setting. Some of those things consist of things, the pace that you have in the primary care setting. In the inpatient setting, nurses may have um, quite a few patients. However, when you think about the primary care setting, you may have more patients per se, but the patients present more with chronic diseases. Whereas usually for patients in a hospital, it's an acute and you're trying to just stabilize them so you can get them out. So remember, you as the clinician, that patient you see, you're probably going to see for quite some time in that outpatient. That's going to become your patient. You will often get to know their family, their children at times. And there also is a level of uncertainty when you're in the primary care setting. Many times when the patient comes into the hospital, by the time you're providing care to that patient in a hospital, as a nurse, you know what their diagnosis is because it's not your responsibility to diagnose the patient. However, as an advanced clinician in the primary care setting, you have to find out what their purpose for coming is. It may be that your patient presents to you for high blood pressure, but what you then glean and begin to understand is maybe they also have kidney failure. Maybe they have other issues. And you sometimes they don't know why they're there. And you are like a detective. You have to collect all the clues, which comes through your systematic assessment of your patient. And then you have to help them to understand where they are. The types of patient you see in primary care may differ from when you were in an inpatient. In primary care, you may get a potpourri of types of patients, whereas in primary care, depending on what unit you on, determines the type of patient you see. Whereas primary care, you have to be, as an advanced clinician, you are required to know a lot or a little bit about a lot. And you're required to be able to access resources that will provide you the ability to provide the best care to your patients in a comprehensive manner. So the dynamics and the uniqueness of primary care, which is so fascinating, and it is fulfilling to see patients in the primary care setting, you do have to consider that there are multiple levels to seeing patients in the primary care setting that differs than the inpatient setting. Let's talk a little bit about the nursing and medical models. So when you think about the nursing model, right, um, you want to think about how nurses and physicians work together. And when we work together, we get a benefit for our patients. So as you can see on my slide, we have the nursing model, we have the medical model, and together these models help us to provide the best care to our patients. As an APRN, what you will then do is take those two models and components of the medical model along with your nursing model to provide the best care to your patient. And that will require you to not only look at your patient, but also look at the environmental factors that may impact your patient. Now let's talk about the different phases of discourse. When you're thinking about seeing your patient, that clinical process that you go through, you must first establish an agenda. Why am I seeing this patient? What do I need to do for this patient? Is there anything that I need to provide to this patient? Then you have to elicit information from the patient. That is your assessment piece, right? That's them coming in and you're doing that comprehensive or that clinical assessment on your patient. And as they're giving you that information, you're going to be alerted to cues. You're going to be paying attention to what the patients are saying. Then you move along to say, okay, how am I going to help solve this problem? What is it that I can do? How do I do that? Then you do your physical exam, which will help you lean your physical exam along with the information you collected, helps you to begin to develop a care plan. And that care plan is one in which you collaborate with your patient about that care plan, what you would like to see occur with your patient. So that plan of care, that management that you're thinking about, and it gives you the opportunity also, because we as advanced practice, it's teachable. So it's not just this is how we're going to treat the reason you came in today, but what are the teachable moments that I have? What is the prevention I need to think about? What is the education that may need to be provided? Are there other resources I need to give my patient access to? And then you personalize it with that patient so that you can establish a comprehensive plan of care for that specific patient. And then it leads us, of course, to our satisfaction, not only us as the clinician, but our patients as well with the care that we've given to them. So let's talk about the elements of the human contact in the clinical process, because there are things that happen. If you think back to the previous slide that I just showed you, that circle has a lot of information in it, and it can be overwhelming for your patients. So as the advanced clinician, being aware and intuitive to your patient becomes important. And remembering when we think about the evidence-based process that we go through and how do we apply that, is remembering that anyone who is learning something, they have to learn it through a process. It starts in our short-term memory, then goes into our long-term. But you have to think about how much information can you give a patient? How do you present that information to the patient so that that information can go from their short-term to their long-term memory? And then you have to think about not only how do we get it from the short term to the long term, is I want you to think about the process of critical thinking on your part as well, and then clinical judgment. So we have our patient, short term memory to the long term memory. What information do you want to give them? But think about yourself as the clinician, your critical thinking, and then your clinical judgment. What helps you and will provide you what you need so that you can critically think. You can reflect on what the patient says. You are able to make good clinical judgments for your patient, as well as for the patient themselves. They can go through that same process. How do you get them to critically think about their health care when they may have other things going on? And then how do you get them to help to get to a place where they can make a judgment? They can then begin to address some of these issues. The big piece to that, I believe, is support. Support not only for the patient, but even the support for the clinician, especially for new clinicians and for patients. You think if you want them to change their lifestyle, you need them to make any type of changes. There's a support that's necessary. And you as a clinician is not the only support that they will need. And then you have to think through, what is that going to look like for you to get the outcome that you want? So, what are some of these limitations to us as clinicians, to why our clinical processes may not be occurring with the evidence based practice the way we know they should be? I would like to say sometimes it is that intuition, right? Think about clinicians or providers, or even sometimes you can think about even educators, people you've known that says, I do this way because I've always done it, or I feel like this is how it should be done. And then that's just the way I want to do it. How does that play a role, and does that prevent from doing best practices? Does that limit the clinician? For you as an advanced practice, it's important. You can have intuition, but your clinical guidelines, reading the latest literature on the disease processes, continuing to do continuing ed courses. These are the things that help us to continue to have and to facilitate and work with good clinical processes, and not be limited because of our intuition or our lack of knowledge. And so, in order to help, just go into up to date. Up to date is a good resource, but there are many that are based in true rigor of the review of the literature that will assist you in knowing that you have a solid foundation as you go through learning how to be a good clinician. Now, let's talk a little bit about the diagnostic process overview. That is where you get data generation and clustering. You build your hypotheses, you problem solve, you match, you plan. Let's think about it this way. Let's give you an example of a patient. Have a patient that comes in with diabetes mellitus and their blood sugar is elevated. So what would your hypothesis be for that patient? Uncontrolled diabetes. And so then you start to think, you know what? Let's think about differentials along with that hypothesis. Okay, so change the word hypotheses to differentials. Uncontrolled diabetes. Maybe medication mismanagement. Maybe lack of understanding. It could be newly diagnosed. Those are hypotheses in a sense. Then now you want to do your probabilistic reasoning and your pattern matching. Where does that come in? I want you to think about that clinical assessment you do on your patient. That's where you're collecting that HPI information. That's where you're collecting that past medical history. That's where you're doing your physical exam. And then your planning. Think about your planning as being your assessment and your treatment management, right? That's where you're saying, this is where I'm going to plan and problem solve. This is what we want to do for this patient. And then that's where you develop that. And then your critical reflection is having that conversation with your patient. Okay, this is what I would like to do, and this is why. Let's have a conversation. What do you think about this? So you see how you can utilize that scientific and information, evidence-based processes, and you apply it to your clinical setting. Again, this just talks a little bit about the same thing. How do you collect that data? How do you evaluate it? How do you support that with your clinical judgment? And then how do you prevent the errors from happening? So I want you to take a minute and think about, I don't know, let's give you chronic obstructive pulmonary disease. Stop this lecture and take a minute and walk through these steps as it pertains to chronic obstructive pulmonary disease, thinking about your systematic clinical assessment that you would do on your patient and plugging that in. Okay? So now I want to conclude with just an overview and talk about one, when we talk about the diagnostic process review, first you reach a working diagnosis. What is the diagnosis you have for this patient? You discuss the management plan with the patient. Have an honest conversation with the patient. What are they willing to do? What are they able to do? And then determine what part of that treatment regimen that you can recommend and that they will follow. Remember to always do a follow-up plan. Example of that is after you see a patient, I'll see you back in 3 months. I'll see you back in 2 months. Or it could even be, we're going to do a telemedicine visit in 2 weeks. My nurse will reach out to you and will call you, or I need you to call my nurse. But making sure that you have a follow-up plan that has been documented and articulated to your patient. Know that your physical examination is important. And when you do the physical exam, you need to make sure that the patient is comfortable with you doing the physical exam and that your physical exam is basically allowing you to be able to collaborate, to kind of corroborate things that you may be thinking and maybe explore and find something that you didn't know was there. But you need to be sure before you do a physical exam that your patient is okay with you doing that physical exam. And if they're okay with that physical exam, then you respect them during that exam. And during your exam, conversate with them and let them know what you're finding. If they're going to allow you to get into their personal space, the least you can do is have a conversation with them about your findings, even if they're normal findings. I think about my patients all the time as I'm looking in their ears and nose. Many patients have never been explained to why we do that. So to just have the conversation, I'm looking in your ear to see if I can see your tympanic membrane. You can give an analogy. I use the analogy of I'm looking for like a sheer curtain that should be blowing in the wind. If I see that sheer curtain and I can see behind it, kind of like when you're looking out your window, then everything looks good if I can see little shadows back there. Things like that. Or I'm looking in your throat and I'm just looking to make sure there's no redness. I'm feeling your knees because I'm making sure that I don't feel swelling. But have a conversation with them about what you're doing and why you're doing it. I hope this helps you see how you partner the evidence that you practice along with your actual clinical assessment, and then how we explain that to our patients and how we partner with our physician colleagues and other healthcare clinicians. But we are a healthcare team that works together for the betterment of our patients.